Graduate of Tulane Medical School in 1931. This series was initiated in the fall of 2013, and it's an endowment to support lectures on spirituality and health at Tulane University School of Medicine. It focuses on the art of creating a compassionate and trusting relationship between the patient and the doctor. This series honors the legacy of J. Richard Williams, Sr., Tulane University graduate who was a well-known and well-loved internist and oncologist in Selma, Alabama. Dr. Williams loved medicine and is described as the kind of doctor who would do anything for his patient, with an interest in the impact of spirituality on health, particularly on the positive impact of spirituality on the well-being and continued health of those who have suffered the loss of a loved one. In addition, this lecture is co-sponsored by our master's program in bioethics and medical humanities. We are a 33 credit hour program, can be taken in 1 year or 2 years, with a track in bioethics or a track in medical humanities. And if you want to learn more about our master's program and our certificate programs, we have graduate certificates in clinical ethics, research ethics, and medical humanities. If you want to learn more about those, it's very easy. tulane.edu/bioethics will get you right to our webpage, and you can learn all you need to there, or you can contact us I'm Stephen Hansen at shansen4@tulane.edu, or Tulane Medical Ethics at tulane.edu. But enough of that. Let's talk about why you're here. Dr. Trevor Bibler, PhD, is an associate professor of medicine at the Center for Medical Ethics and Health Policy at Baylor College of Medicine, and a bioethics program director at Houston Methodist Hospital. He's a clinical ethicist with a background in religious studies, postdoctoral fellow in clinical ethics at Baylor and Houston Methodist, and earned his PhD in religious studies from Vanderbilt University. He teaches a variety of audiences and writes on religion and medicine, methods in clinical ethics, and novel clinical technologies. And he's published widely in the top journals in clinical ethics, pediatrics, general medicine, and critical care medicine. The research that informs today's talk focuses on the ways that religious worldviews, especially worldviews that include ideas related to miracles, influence clinical medicine. With that, let me just hand it over to you, and hopefully the share works better for you.
Sounds good. We'll give it a shot right now. Let's see, I'll put myself in presenter mode. Are y'all seeing a slide and then closed captions?
Yes.
All right, then I suppose we can get started. Okay, so thank you very much for that introduction, Stephen. I appreciate it, and I appreciate the opportunity to be part of such a august series as y'all have put together here at Tulane. So I'm really grateful for the opportunity to chat with y'all a little bit. And as was mentioned, what we're going to talk about today is this challenge often of when patients hope for a miracle. And what I'd like to point us toward is better understanding and some very concrete practical responses. No conflicts of interest or obligation. 3 goals for our hour together. First, I want us to just very quickly find a shared basic vocabulary just to make sure we don't talk past each other too quickly. Appreciate the complexity of a hope for a miracle, just how complex that can be. And then what we'll spend the vast majority of our time doing is developing justified clinical, and then I'll gesture toward institutional responses to some of the challenges that arise here. If those are our goals, what's our pathway? This is our pathway. I'll talk about some orienting terms. I'll introduce a very broad, very general case of Mr. Marcus, and then we'll dive into these responses. And the responses build on each other. First, we'll talk about beginning the conversation through inquiry. After that, we've asked questions, so we'll hopefully start understanding the answer to those questions and add some analysis into that. And then finally, I want us to think through what a focused reply might look like based on these other 2 steps with very intentional practice, not appeals to our own personal experience or our guts, but a very intentional practice here. A couple reminders right at the outset. as y'all heard, I'm a clinical ethicist, so I feel like everything I say is really informed by that aspect of my professional identity. So I might emphasize some aspects that you might not emphasize, or miss out pieces that other healthcare professionals might emphasize. This is going to be a whirlwind tour. We don't have too much time together. I'm going to focus on adults and not pediatrics. We have a paper in pediatrics if you're interested in that side of things. I want to highlight that there's no one-size-fits-all approach to this, really. As an ethicist, I want to focus on process, not product. There's nothing that I'm going to say that promises a easy fix or a snap of your fingers and then you get an outcome. It's really going to be about a process that hopefully is robust enough to change the conversation, but no guarantees of that, obviously. And finally, I want to make it very clear that what the responses that I'm going to be discussing and sometimes even recommending, they hold, in my mind at least, independent of your own spiritual identity. Because what I'm trying to have us do is rely on our professional and ethical obligations. So whether you're theist, atheistic, agnostic, apathetic, doesn't really matter. Because what I'm going to be appealing to are the ethical and professional foundations of clinical medicine rather than your own confessional beliefs. I don't see them as necessarily an impediment to this conversation, but it's not a requirement that folks have any kind of specific confessional basis. And as I was just reminded, so I'm traveling right now, and I have my sick cat right next to me. So if you hear cat jumping around and meowing, she's doing okay, but it might be a distraction for us. But she should be fine. She's quiet right now. Let's start off. First things first, sharing some terms. Moral frameworks. What are we talking about here? Well, these are systems of belief and practice that inform a person of their ethical responsibilities. That's the working description, really, more than definition I'm going to use. And we can appeal to our moral frameworks when we ask the questions, what should I do and why should I do it? And I want to specify 3 types of moral frameworks which overlap, but are still, in my mind, distinct. A secular framework, that's where we have the social beliefs and practices of a culture are centered around non-sectarian or non-spiritual ideas and practices. So for example, from a secular framework, we might appeal to the dignity of a patient based on appeals related to humans' abilities to reason, for example, or participate in virtuous activities and so on, rather than an appeal to, well, the reason why we should treat our patients with dignity is because they're made in the image of God, right? That's a different type of appeal. That is an appeal that is linked more closely to a spiritual framework. That's where you have an individual or a community search for transcendent ultimate meaning using these diverse modes of communication. And by that, I mean sometimes it's quite meditative, reflective, sometimes it's more communal based, sometimes it's prayer. And then the final framework I'll mention is a religious framework. That's where an individual and their community search for some type of transcendent ultimate meaning with some shared religious, but spiritual as well, moral frameworks and modes of communication. The main distinction I want to make here is between those frameworks, on this slide at least, is between those frameworks that are searching and sometimes finding the transcendent based on whether it's solely individual or part of a more communal effort, because that will end up playing a role in how I think that we should respond to it. For those of us who are more visual learners, just wanted to pop this up. Vastly oversimplified graph here, but if we think of our moral frameworks like this, our moral frameworks can encompass secular frameworks, spiritual frameworks, and then religious frameworks are within that larger domain of spiritual frameworks. And for the sake of simplicity, I didn't do overlap, but obviously the secular frameworks, the spiritual and the religious can overlap, and we have more of a Venn diagram there. But this is just for more of our visual learners, such as myself. Let's jump into a case here. Very general. If this was in the clinic, we'd have lots of follow-up to do, but I want to keep things pretty simple. This is a case of Mr. Marcus. We'll call him a 79-year-old non-Hispanic white man. He came to the ED a couple weeks ago with some confusion, shortness of breath. He was tachycardic, had some facial drooping. He was quickly placed on the vent, went to the ICU. He's been in the ICU for quite a while. It's day 15 on vent support, but he's still not stable enough for a trach. The diagnosis is that they're very confident is that he has respiratory failure, permanent respiratory failure, secondary to pneumonia, and he's also had a series of stroke, as we might have suspected in the ED with this facial drooping. The prognosis from their perspective is that he's unlikely to recover his cognitive function or his ability to interact. And there's this rumor that you hear that the family of Mr. Marcus is hoping for a miracle. So let's take us to a slightly different moment. Let's imagine we have a conversation with Mr. Marcus's family, and it goes well, but it's fairly broad, fairly general. And the upshot of it is that the family is continuing to request life-sustaining technologies. And the response from the healthcare team is that they believe that further interventions are either just simply impossible or inappropriate. And ethically, what we're trying to do here is trying to find this balance between respect for autonomy, which has to, if we're doing shared decision making at least, would have to include some consideration of the patient's preferences and values and wishes. But we're also trying to balance the professional integrity piece, where healthcare professionals are, as part of their professional identity, appealing to their ethical identity as well, is to minimize physical harms at least, and avoid those wrongs that can be avoided. And we're going to set this aside here, but I'd be glad to talk about it during the Q&A. Sometimes another piece of the balance is trying to find some fairness in the just use of resources, but we'll just set that aside for now. What's our task then? Let's imagine we're in that moment. I think what our task is to find some type of justified, rigorous, but also practical response that strikes this proper balance here. And then if we're able to find that balance, how do we implement it? That would be our next step. So we have dueling tasks here. And where I want to spend the rest of our time is in focusing on 3 responses that might end up being helpful for these types of situations where, as I mentioned, we begin the conversation with inquiry, we try to understand what we heard with some analysis, and then we take an intentional shift in our perspective and try to offer a very focused reply based on what we've heard with an intentional practice. So let's start with beginning the conversation. Let me see here. Sorry, just one sec. I've got my bar here in an odd spot. Okay, there we are. So we're beginning the conversation. And I'd like for us to think about beginning the conversation by actually looking at a professional level, looking inward. And what I mean by this is that I've met many healthcare professionals who are reluctant or reticent to even put a toe into the waters of talking about miracle language because they're not sure how to begin the conversation. Now, I, as an ethicist, have a pretty easy way to jump in, and that's because my job is to help elucidate values. Part of my job is to help elucidate values. But depending on who you are, what your job includes, sometimes maybe even what it might entail, there are different ways of framing this, and I wanted to throw one out there, is explicitly naming that part of my job includes, and then what that might be, often follow-up or additional conversation about these ideas, concepts, and practices that are most important for you as you're making these difficult medical decisions, something along those lines. And you can say, that miracle has different meanings. You've probably heard it used in different ways. And you don't want to assume what a miracle might be for Mrs. Marcus or Mr. Marcus. So can I ask you, Mrs. Marcus, more about what this hope might be? Now, what this does and what I want to highlight are a couple things. One is that the motivation is seen as being very professional, right? You're not appealing to some personal attempt at getting more information from them. It's a professional inquiry because you framed it by appealing to your job, and your intention is to have a better understanding of what they mean. Now, it might be just my idiosyncratic luck, but when I've done this framing as part of these conversations and these initial pieces of inquiry, I haven't really heard feedback or gotten a stonewall that says, no, I don't want to talk about this, right? Because they are using this concept to make to inform their medical decision making. So in my mind, at least, it's up for grabs conversation. Beyond that, let's talk about what you're likely to hear when you dive into this question is some type of support from a church, mosque, temple, synagogue, and you can name that, and then follow up a little bit more and ask them to tell you a little bit more about their community. Why that, in my mind, is especially important is because then you can listen in on where there might be overlapping or similar views between the invocator and their community, or where there might just be disagreement. And what is especially helpful to remember is that when you ask these questions is that we can't assume that the final spiritual resource for a patient's conception of a miracle is a official resource that's vetted by their religious organization. It might be their aunt who has been through something like this, right? So listening in for those additional resources can be of help. And then the final two pieces of this initial salvo has to do with clinical understanding and eliciting values. And there I'll give some additional language that I've found helpful. So we want to get some sense of the invocator's understanding of the clinical situation, right? So you might say something like, I'm sure a lot of people have been telling you a great deal about how Mr. Marcus has been doing and how he might do in the future. What have they been saying? Now, notice what this does. We still want to get at what Mrs. Marcus, we'll simplify and just say it's Mrs. Marcus, what she understands about the clinical situation. We still want to do that. But notice this question displaces the responsibility to the healthcare team a little bit more directly, saying, we're the ones responsible for getting you up to speed. We're the ones who have been talking to you. Based on your understanding, right? What have they been saying about how he's doing? So you're still getting at her understanding, but it slightly displaces it rather than the question that I hear 90% of the time is, well, what do you know, right? Or how do you think he's doing? Something along those lines. This says it first and foremost, it's a clinical care team's responsibility to help you get to that point. And if you do this routinely, you'll have to resist the writing reflex. You will hear something clinically that is inaccurate, or they get something wrong about the time frame or somebody's intention. Resist jumping in right at that moment. You'll have that chance a little bit later on. We're at a different moment right now where we're beginning the conversation and we're hearing them out, trying to get their clinical understanding of things. The other piece is eliciting or elucidating values, depending on how you want to think about it. Now, if you leave this lecture with anything related to values elucidation, I hope it's this. It's that if you ask a question, let's imagine we're asking this of Mrs. Marcus, what did a good day look like before Mr. Marcus, before he arrived at the ED, right? Something like that. If you ask what a good day looks like, then you'll also get a sense of what a bad day might look like. And there's intrinsic value in asking this question because it's just good to know about our patients and how they value their own time, what they find meaningful, right? But there's also a great deal of instrumental value, because I'll give it an example from my recent experience. When I ask a question like this, the patient's spouse appealed to a watermelon seed spitting contest that the patient and his grandson had recently had at a cookout. And when we got to the point of the clinical care team meeting and the neurosurgery team saying there's less than a 2% chance of meaningful neurological recovery, I was able to help transmogrify that point, I suppose, into saying what I'm hearing from the neurosurgeon is that he's never going to have another watermelon seed spitting contest. Okay, that I got to that information because I know what a good day looked like for him before and what a adequate day might look like from there on. But that's a side point, but it's in my mind a very important values elucidating question. Now, I want to turn very explicitly to a question that you might already have in mind of, well, oftentimes we're not talking with the patients directly in these situations. And if we are talking with them directly, it's a little bit easier, right? So what do we do when we have a surrogate and we're inquiring? I would say that we have similar questions as we might have with a patient, but there's an additional requirement on behalf of the healthcare team, and it's that they have to provide, and then they also have to look for a distinction between how the representative describes their own beliefs, their own values, their own interests, and that of the patient, right? A basic point, but what might be some language can say something like, your religion, it's very clear that it's very important to you. Can you tell me a little bit more about uh, Mr. Marcus's religious beliefs? Something along those lines. Or if they mention their community, as they're likely to, did Mr. Marcus also have a similar relationship with his mosque, right? Or what would Mr. Marcus say about miracles? Very concrete language when we're inquiring with a representative. Now, what happens if it turns out that in your mind, the representative isn't doing a good job of, let's say, understanding the distinction between their own spiritual interests and the physical interests of the patient? Well, you might say something like, the responsibility of acting as a surrogate means that you focus on Mr. Marcus's idea of what good medical care is. This means putting yourself in his shoes and making a decision that he would make. I'm seeing you struggle with this. Do you think that if we work together, you'll be able to get to that point, being able to think through with him? And here, I think consulting chaplains and ethics can be especially helpful. Now, if we hear from the surrogate a strong argument, they're obviously making a substituted judgment, great, no problem. We'll continue conversing. But if you come to the conclusion and you have a strong argument, really, that they're failing, I would imagine this often happens when they're placing their social and psychological, especially their spiritual interests, above the patient's physical interests or their dignitary rights. If you come to that conclusion, then in my mind, the surrogate needs to be removed, but that would be only after in-depth discussion. And I should say removed probably as a representative or have additional support as a representative, not necessarily no longer part of the conversation. Here you see a neat little table that I'll be glad to send out. So we've been responding a lot. We've been asking a lot of questions. It's likely that we've heard different answers, right? Why? Because we're asking about a clinical understanding, we're asking about miracles, we're asking about communities, and we're likely to hear some variation as part of that process. Now, this shouldn't surprise us, just given how complex the spiritual facets of who we are can be. Now, one helpful way of understanding all of this complexity that we're seeing is through a taxonomic analysis that I'm going to put forward here. Right, MedEd, we love acronyms. IRS, that's going to be our acronym for today. Integrative, reactive, and seeking invocations of the miracle. And I want to highlight here, you'll notice I bold and underlined. I forgot to italicize, but I probably could have done that too, where I say one, right? In my mind, this is one way of understanding this complexity, not the way, and it's a helpful way. So I'm not saying the right way of understanding. I'm saying one helpful way of understanding. So please keep that in mind. I'm not trying to dictate anyone's practice. I'm trying to offer some ways of thinking through this that might end up being helpful. Let's jump into integrated. And you might already be imagining what an integrated invocation might look like. This is where the patient's or the family's beliefs are long held and they have a great deal of community support. Their sense of who they are, who God is, what's divine, what the community looks like is very tightly woven. When you go into the room, you'll see often sacred texts. They're at hand and they're well known, sometimes able to be quoted from memory. Worship, whatever that worship might look like as part of their religious tradition, is necessary in their minds and just a long established part of their life. Prayer might be for a cure or faithful guidance. I mentioned that because that'll be different a little bit later on. Now, how does an integrated invocator see the relationship between medicine and divine? Well, the world is a place where miraculous healings can occur, and secular medicine's worldview, their framework, cannot account for that whole. Right? We're not saying that secular medicine has no role in this, but the integrated invocator would see the divine as separate from the secular, and the secular as being a bit myopic, It just can't take in the whole picture. Illness might be seen as a test of faith, a chance to show love to the divine. And I want to highlight here, because I hear this all the time, is that an integrated evocator, in my mind at least, is not in denial in any technical sense, right? They have a worldview that can account for illness, and they're applying that worldview to the situation. That, in my mind, isn't denial. That isn't reactive coping. This is something different. And you'll often find that those who use miracle in an integrated sense have a good clinical understanding of what's going on, but their conclusion is that, look, we just have to prioritize the religious framework, not the secular framework. That's one way of thinking through things. That's not the only way of thinking through things. What about those who are reactive? Here's the R in the IRS. Well, here we have beliefs where where the invocator has recently turned to a religious community or makes spiritual appeals, or sometimes even it's just kind of a mild gesture toward religious beliefs, but it's recent. The community isn't heavily involved because they don't have a community that they can rely on. So there's not this close connection between self, cosmos, and community. Sacred texts won't be at hand. Worship, they either don't worship or they might have a distant history that they would appeal to. Sometimes they might not pray at all, or if they are praying, it would be for a cure, not necessarily, or not for guidance, but for a cure. Here, the relationship between medicine and the divine looks different, where medicine is desired, but divine appeals are just unimpeachable. There's no place that there's nothing medicine can say about how I hope for a miracle. So they're just separate, have to be separate, not overlapping or not encompassing enough, as we saw with the integrated invocator, but they can't overlap, but there's still the request that secular medicine continue to move forward or add additional technologies. Now here, I think we're a little bit more comfortable, I would at least be a little bit more comfortable saying that since this is a reaction, I've baked it into the word, this is the response to the stress of a situation, not an application of a long-held worldview. There's probably some type of personal conflict here. And you see that or you might come to the conclusion, at least, that there's an attempt to gain control over others. Those others might be other family members or members of the healthcare team. This is probably based in feelings of powerlessness, either toward other family, the institution, the team, or generally the world. And what I found to be especially the case is that there's distrust somewhere, right? If there was ample trust going on here, the healthcare team would make a recommendation, that recommendation would be trusted, and then they would move forward. But we don't have that here. And the language of right to, like, I have a right, Mr. Marcus has a right to the tracheostomy, right? That'll be present here. Now, note here, I get the sense sometimes that when I talk about this reactive response, it feels judgmental. Like when people do this, they're doing something wrong or improper. I'm not trying to make that point, especially when there's a loss of trust fueling this. I think that reactive response is sometimes very well justified, right? If the stress of the situation is leading to this type of conclusion, the patient or the family is feeling absolutely powerless, and they realize that there's some language that they can latch onto and use that gives them power. It makes sense that they would want to latch on to that, especially when their loss of trust is justified, right? So I'm not trying to make a designation saying that integrated is right, reactive is wrong. It's nothing like that. I just want to highlight, though, that unless we're honest with ourselves and say that there's something very different about somebody who uses a miracle in an integrated sense and in a reactive sense, then our responses aren't, I think, going to do justice to the complexity of the term. Finally, those who are seeking. And this is probably the most prevalent category that I, at least, and my colleagues who I work with on these topics have found. So seeking also, I think, I hope it's pointing toward what this might be, is the patient or the surrogate or the representative They have beliefs and they're looking for some type of faithful response, but that response isn't as manifest and obvious as it might be for somebody who's coming in from an integrated perspective. So here, someone who's seeking has a close relationship with their community, but it's not as if there's this one-to-one where community belief equals the belief of the person seeking the miracle, right? Community does not necessarily determine the answers here. The sacred texts, they are probably well known and they may very well be at hand, but they might not. Worship is still likely to be seen part of life, but what they're trying to discern is what a faithful response might be. Prayer, in this sense, for somebody who's seeking, is for guidance. It's not for a cure, in no small part because it might be the case that they're not sure what a cure would look like, so they're looking for guidance. A bit more about the seeking invocator. Here, there's the relationship between medicine and the divine is often seen as complementary. There might be some questions, there might be some concerns, but there is a complementarity that goes on because those who are seeking end up often seeing medicine as an implement of God's will. Illness is part of the world, it's part of the divine plan, but they're trying to figure out how that can be the case. They don't have the answer to that question. They're not in denial, they're inquiring. Here, clinically, they'll have a good understanding of what's going on, but they're also comfortable. Comfortable is probably not quite the right word, but the uncertainty hasn't shattered them, right? The fact that they're praying for a miracle and they don't know what that miracle, that they could be praying for a miracle and that they don't know what that might look like is uncertain, but they still have a community to rely on. They still have each other to rely on, and they're working toward a faithful response given the challenges that they're seeing in the clinic. Here is our little taxonomy. And then now I will get to our final step. Good, we are right on time, offering a focused reply of intentional practice. So what I want us to think through first are a couple responses that I think after we ask and analyze are probably going to be applicable to any person hoping for a miracle, any of the three. One is that you are going to want to continue the productive conversations that you've already been having. You've been accruing understanding of them. They've been hopefully accruing understanding of the clinical picture and your motivations and your intentions. Yeah, you're working toward an understanding that is truly mutual, truly working towards shared decision making in a very robust fashion. And it can be helpful in all of these scenarios to affirm a commitment to the patient's well-being, or however it feels most natural for you to say that. But even when we do have disagreement about whether or not the trait's appropriate, there's still a shared understanding that both sides want what's best for the patient. It's just competing ideas of what's best here. So there is that shared commitment. Scenario-focused reasoning can often be helpful, and I'll talk about that for one of the responses more specifically, but working with best case, worst case, most likely scenario rather than percentages can sometimes alleviate the burden that healthcare professionals feel in saying those percentages that, I should say, in committing to those percentages that patients and their families often want. And for all of this, what you're going to be wanting to work toward is finding the connections between the values that the patient has, what their preferences for medical interventions might be, and then what's the heavy lifting of the task of the healthcare team is then figuring out what goals are feasible. And with my watermelon seed spitting example, you can see how all of those have to come together and be connected. All right, those who use miracle language in an integrated sense, what might that look like? Something you might consider is including those religious authorities who have so heavily influenced the invocator's conception of miracle here. Now, let's imagine you call in the imam who Mrs. Marcus trusts. It's probably not the case that this is the first time he's dealt with a situation of having somebody having one of the faithful go through the dying or death of a loved one. It's probably not their first rodeo in that sense. So they've probably dealt with similar situations and could very well be a asset in the conversation. But remember, your goal here in trying to ask more, and I should say, it's more of a reminder of an invitation to the patient or their family to invite those people into the conversation, not you inviting them directly. But the goal would be a better understanding of the community's position. Why do I say community there? Because we have such a heavy overlap between the position of the community and the position of the individual invocator here. And this demonstrates a deep, serious respect for the way that they make medical decisions, even if you think they're wrong, even if you disagree. It's still, right? You can disagree with someone and still demonstrate a great deal of respect for them. And that's what we're trying to do here. And reminding them that they can invite the people that they trust most in their medical decision-making process into the conversation can be helpful. Now, another nota bene, they might end up agreeing with the invocator, right? They might say, oh yeah, no, a faithful response here is to keep moving forward, get that trach pace, get that peg placed, go to the LTAC. That's part of the risk of inviting these authorities. And there's been a little bit of empirical work on this done in pediatric settings, but this is another spot where my professional background as an ethicist is highlighted, because I'm focusing here on a process, not a product, not an outcome, right? Because if I thought the only important thing here was the outcome, then maybe including a religious authority isn't the right idea. Maybe that's not the right path moving forward. But that's not our goal. Our goal is to work a justified, robust, and rigorous process and see what happens from there. Also, with those who are integrated, if it turns out that you as a healthcare professional are very concerned about what's going on here and how these spiritual beliefs are playing a role, you can be straightforward with your concerns. And I'm using a little bit of technical language here when I say that. The concern might very well be that the spiritual interests, in this case of Mrs. Marcus, is being prioritized over other competing interests of the patient. Like, let's say that this is controversial, right? But let's say that the patient has a right to dignity, and if the healthcare team comes to the conclusion that Mr. Marcus's dignity is being violated because of the spiritual interests, saying that is going to be important. Obviously, you would say that in more simplified terms that I'd be happy to talk more about in the Q&A. But ethics analysis wise, that is probably, when you get into situations like that, that's probably your overriding concern. It's that the psycho-spiritual interests of the surrogate are being prioritized above the physical interests or maybe even dignitary rights of a patient. Not always, but in the most difficult cases, that's happened. And that seems to happen often with integrated and reactive invocators. The emphasis here for the team is on this shared desire for what's best for the patient. That seems especially helpful in these situations. And then a final piece of advice for integrated invocators that I realize probably applies across the board a bit more broadly, but I found a special help with this, is that I've met so many healthcare professionals who say, look, it's not my job to take away anybody's hope. I'm not going to talk about this miracle stuff. It's not my job to take away hope. Agreed, that's fine. But we need to make a distinction in our minds and talk with our patients about the distinction between a hope and an expectation. A hope for a miracle is something that exists outside of the hospital walls and probably exists no matter what might happen in the clinic for these integrated invocators. But you all, as healthcare professional, have to tell the family what to expect. You have to tell them what you would expect to see if we go down the long-term acute care trach and peg route, right? And that's not meant to take away their hope, but you, as healthcare professionals, you have a requirement to tell them what to expect based on your reasonable medical judgment. And sometimes that might diminish hope a little bit, but that's never your intention. Your intention is not negotiation and it's not dismissal. It's to tell them what to expect if we go down this path while recognizing that they can focus on what they might hope for. That's that piece. Then I just have some sample language here where we would incorporate, if an integrated invocator is hoping for a miracle, sometimes it might be helpful to name that miracle as a best case scenario rather than a most likely scenario. So it's your job as a healthcare professional to tell them what to expect down this most likely path. Ensuring a unified message between members of the healthcare team is going to be extraordinarily important here. And making follow-up plans that are specific is also going to be important. Next, reactive. Recall, this is a different challenge, right? Because authorities are often absent. Unclear communication is often present. So routine team meetings and routine patient care conversations, or family meetings as they're often called, with a single goal can be very helpful to restart the conversation. And in my experience, in the experience of some of my colleagues, distrust is often the motivating force, right? Because they're trying to latch on to language that gives them power because they no longer trust the healthcare team. That distrust might come from a single event, from overall experiences of powerlessness, from a perception, either accurate or not, of mistreatment. But what can be helpful here is a separate conversation with the question, what can I do to begin rebuilding trust? I recently asked that question in a context like this, and it ended up being very important that the patient's family see the chart. And as if you ask a question like this, it's also going to be very important to make sure you don't overpromise, right? Like, let's imagine they say, I need an apology from that surgeon before I move on. Probably be very unwise to say, okay, I'm going to get you that apology, right? You have to really think about your professional obligations and where you might be able to help rebuild trust. And this, what I keep, I want to appeal to, recall, this trust may be very well justified. So continuing to facilitate communication while also seeking areas for rebuilding is going to be very important. Also offering extra, additional institutional resources like chaplains, but chaplains are often rejected here, but grief counselors, social worker, any specialist. But again, we see the importance of being explicit about a reorientation to a mutual commitment to good patient care. Finally, those who are seeking. Here, they're looking for the faithful response, right? So chaplains and other spiritual authorities might be extraordinarily helpful here, unlike with both the integrative and the reactive. I think chaplains should be part of all these conversations, but here they might be especially helpful. So you have to ask them. But remember here, their concept of miracle might fluctuate. So having routine conversations to see how this idea of miracle develops will be very important. And surprisingly, if they're truly seeking it, it often ends up that their decisions align with the healthcare team's recommendation, but it's just over time. It takes a lot longer than anybody on the healthcare team would prefer. This is why, for those who are seeking, time-limited trials are especially helpful, like saying to Mrs. Marcus, look, it's day 15. If we're at day 21 and we still have no progress in our spontaneous breathing trials, assuming she knows what those are, then I'm very confident his vent support is going to be permanent, right? Something like that, that gives them the opportunity not to put a stopwatch on God. It's nothing like that, but they're trying to discern what a faithful response might be, and clinical information can be important for them. Here, again, we have that. So let's imagine you say to me, Trevor, I've done everything you've said. I've done it to a T. We still haven't gotten anywhere. I'd say, well, you've gotten somewhere. It just might not be where you want to be. But even with sustained conversation, there's no guarantee of this. This is where remember, one of our goals was to talk about the institutional aspect of it. This is where the institution has to come in. There have to be processes and policy that promote a fair solution, that even after weeks, many patient care conversations, we still are at loggerheads and we can't move forward. There need to be venue for discussion and formal recommendations where the institution has some skin in the game. Because here we have a formal weighing of professional obligations and patients' interests and rights. When we get to this point and the institution has ushered and put forward as much support as they can, they need to now weigh into this. There has to be, if we're thinking of an algorithm for everything I've spoken about, one of the endpoints has to be the institution getting involved and offering recommendations. Preventative work, this will be obvious, but I just want to name it. Clear routine communication, routine sit down patient care conversations or family meetings can be extraordinarily helpful. Well-timed, and i.e. usually that means early, inclusion of chaplains, social work, ethicists, management that can help prevent. And then community engagement is becoming more, fortunately, more a part of routine medical care. Institutions are trying to figure out how to successfully engage their community. So having an eye out for that, I think, is important as well. All right. Final piece. Here were our goals. We wanted to find a shared and basic vocabulary. I think we did that. We wanted to appreciate the complexity of a hope for a miracle. I think we spent a lot of time doing that. And then we also spent the bulk of our time trying to develop justified clinical responses and even institutional responses to these challenges. All right. And so with that, I will thank you. I want to acknowledge Dr. Devin Stahl and Dr. Ricky Chenal, who have when I have talked about my colleagues generally, it's probably them and a couple others that I'm referring to. And here you see my email address. If anybody would like, I know that this is recorded, but if anybody would like a PDF copy of this presentation, just feel free to email me at bibler@bcm.edu. And with that, I will stop sharing my screen. And we have just not as much time as I wanted, but a couple minutes for questions.
And I will gladly moderate that. Just ask your questions in the Q&A or in the chat, and I will follow them up. So question, you said you weren't going to talk about peds, but how do you modify, if at all, for the pediatric or neonatal population? Oh, you're muted.
Thank you. Sorry about that. I will put in a plug for the article that we wrote where we go into a whole lot of detail about that. But there are two main differences. One is that when working, most of the time, you're not working with surrogates, you're working with guardians of some fact. And that can really affect the way that the conversation goes. The other aspect is related to that, but is especially important, is that it's probably unlikely that the patient has had a chance to, let's say, come to a robust understanding for themselves of what a miracle might be. So digging into what, if at all, the best interest standard might have to say about situations like this, that presents the other big piece. But our article is in pediatrics, and it goes into a whole lot more detail and actually modifies the taxonomy in addition to modifying the responses.
I will take moderator's privilege here and ask a question. The palliative care team that I used to work with in another hospital, had a phrase that they used. Sometimes you have to destroy hope in order to create a new hope. And I always struggled with that, but I did see it being quite successful. You talked a little bit about hope, especially in the integrated community. Do you find that you are creating different hopes when you're working with this, or merely meeting them where they are?
Yeah, that's interesting. So I'm not quite sure. I think in my experience, at least, especially for this notion of, destroying hope, I'm actually not sure. So it doesn't destroy hope, right? What it does is it places hope in a different lens. And if it turns out that that hope was actually an expectation about a clinical event, that might be destroyed. But hope is a disposition, right? And it's also sometimes not even propositional, right? There's this notion of false hope. That in my mind is difficult to wrap my head around, because it's not as if hope is a proposition, right? It's an attitude. And then I found that and sometimes it can take propositional status, obviously, but I found that we as healthcare professionals can often do a good job of not trying to mold hope for them, but help them figure out where hope and expectations are disaligned or misaligned, I suppose, and then thinking through with them if they'd like to, or without them, giving them some time as to what this new expectation might have to be based on the professional judgment about what's going to happen next.
And someone has in the chat said, I prefer the phrase changing the focus of hope as opposed to destroying it. And of course, I want to point out that was not language used to patients. That was language used in discussing it, but still, yeah. But right, that was part of my struggle with it. I think it was that. So changing the focus of hope, I think, sounds quite consistent with what you were saying there, perhaps.
Yeah, that's right. And I've also, akin to that, I've also heard the language, especially from my palliative care colleagues, and Dr. Chanel is, he doesn't do palliative care right now, but he did at one point. And there can be this appeal to allowing medicine to do its work, right? And let us be the instruments of God and so on. And I've seen some success with that. I think conceptually, I might have some questions with it because I've also had situations where families will say, yeah, y'all are, I agree, it's important to use medicine. Y'all are tools of the divine. Y'all are miracle workers, right? So let's use those tools. And that's where it can be a little bit difficult. I mean, my response to that has been the equivalent of fair. That's true. If we're using this language, though, this tool related language, there's still a question of, well, how to use that tool properly. And so maybe a trach in this case isn't a proper use of a tool, even if the tool is available. But that might be a little bit recursive and too specific for this conversation, given how specific it was for the patient and the family. But my point is that I think as long as we take a self-critical lens about the language that we use, we're going much further than most of our colleagues on the spirituality side of things.
Let me remind everyone that the link to CME credit is in the chat. You simply go in and fill in your information and things will go from there. Please give us some time. So before you contact us about where's my CME credit, we are working on it. Comment, I find this taxonomy really helpful in conceptualizing the various stances of different patients and families. And the intentional practice of facilitating communication and understanding for all stakeholders. Thank you very much. I think that that's really good. Just the question right at the beginning of what does miracle mean to you, I think has got to be a really useful tool in this situation. Yeah, I'm going to have students follow this, so I'm going to follow it.
Yeah, just a word about the taxonomy. It's not, I should have said this, it's not meant to be comprehensive, right? It can't be. This is more about convenience. And the other piece is that it's heartbreaking, but sometimes you might find somebody going from a integrated approach into a seeking approach, right? The events that they see in clinical settings, people can jump between these, not easily, but still it very well might happen. And I should also say that I don't mean to be critical of anybody who uses the reactive approach and they're starting a spiritual journey. So even if they don't have the community now, that's what they're aiming for. That makes complete sense to me. It's just we still, I think, have to think through this distinction between an N of one spirituality and a religious community that we can ask questions of.
Well, we are at time. Requests definitely, a request was made that will this be available for the video be available for colleagues to watch? And the answer is yes, it'll be available on our website as soon as we get it downloaded and edited and ready to roll. And I believe, although I won't promise this, it will also be available on our YouTube. So yes, there will be ways that you can watch this. I want to thank you very much, Dr. Bibler. This is wonderful, wonderful tools. Oh, final question, and I do like this one. Is it ever okay for, and I'm sorry, I'm not saying I didn't like any other questions, but I'm gonna interrupt my closing to say this. Is it ever okay for an MD, or I'll add an ethicist, to pray with a patient?
Oh, yeah. Great question. Um, I'll also appeal to an article I have out in Heck Forum that specifically appeals to ethicists and how they might use their own spirituality, or how they might not use their own spirituality as they encounter those cases. I think overall, to give a very broad answer to that question that might get me in trouble, but it's where my mind is going. I think that depending on the comfort level of the individual ethicist or MD, that can be extraordinarily appropriate. The only piece that I would always try to avoid is misunderstanding, as if you would give the impression to the patient or the family member that you're agreeing to something like their hope for a miracle that you might not be agreeing with. So sometimes being very explicit and frame how you are going to be praying, or how you might participate or how you might not participate. And I'll just close with this. I don't feel comfortable doing that. So what do? I tell the families that, well, I'm not comfortable doing that, but I can tell that your spirituality is extraordinarily important for you, and I want you to have resources for this. So what I'm going to do as soon as I leave this room is I'm going to make sure that the chaplain comes by, and even if and they will also have the opportunity to pray with you as well. I've had that question maybe 4 times. I've used that response maybe 4 times, and it's never hurt my relationship at all, because I'm explicit about what I'm doing. I'm explicit that I don't want to mislead them, and I give them the institutional resources that I think they're actually asking for.
Yeah, that sounds like a wonderful answer. Thank you. So thank you for your time. And yes, we will have this up posted as soon as we have time for it, as soon as we have time to get everything done and get it posted. And I am so thankful for your time, sharing your time with us. This is wonderful.
Yeah, of course. Appreciate the invitation. Thanks for attending, everyone.
Thank you, everyone. Bye.
Bye bye. Bye bye.